welcome everyone to the Spruce webinar today. For those of you who are not familiar, Spruce is a communications platform for healthcare professionals. And we are very excited to share today some of the ways that Spruce can be really useful for documentation and also for helping with patient care, especially in the mental health field. So I'm Michelle. I am the new implementation specialist at Spruce. And prior to this, I was the practice administrator at a large mental health care company. So my experience with these sorts of insurance billing situations is based upon having worked for a practice that dealt with a lot of very high acuity patients, where we were dealing with a lot of crises and more complicated situations on a regular basis. So it was very important for clinicians to be aware of the coding that is relevant in those situations. So I'm excited to share a little bit about that with all of you today. And I hope this will be useful information for you. So exciting. Today,
I just wanted to do some housekeeping before we got started. Thank you for attending, everybody. Just wanted to let you know this webinar will be recorded. So if you have to go midway through, know we're going to email you a recording of this. And also, you'll see at the bottom of your screen, if you hover over the Zoom, there's a Q&A. And so that's where we're going to want you to put in your questions as you think of them. So please make sure to throw them in at any time, and then we're going to address them a couple times throughout the presentation. We also will see about, someone asked about getting a copy of the presentation. Yeah, we could probably do that as well for you in that email follow-up. Anything else, Michelle, just before we get started, housekeeping wise? And I'll be answering the questions behind the scenes, by the way. I'm Jessica.
Thanks. Yes. Thank you for handling that chat portion for me. Yes, so definitely put in questions. I am going to be answering questions in two parts today. So we're going to talk about crisis coding first. So if you do have questions on that portion, please put them in right away so we can focus on those first before we move into talking more about interactive complexity. So mental health insurance billing pain points, as I'm sure all of you are extremely aware. Time spent on documentation. This is a huge problem for practitioners. If you have spent your entire day handling a patient crisis and then you need to document it, and that's going to take more time, that can really lead to a lot of burnout. We really find that burnout in the mental health care field is often very much fueled by dealing with the requirements of documentation, as well as work outside of sessions and supporting clients in crisis. So part of what we're going to focus on with the insurance billing today is having you be better compensated for these elements of your job that may be necessary and maybe things that are taking up a lot of your energy. So please also complete the poll that's coming your way so we know a little bit more about your audience. I see this is popping up now. So this is just asking about the coding you're using on a regular basis. Some of you may always use psychotherapy codes. Some of you may be using E&M codes more often. Some of you may not be using codes if you're primarily doing just out-of-pocket billing. So just so I have an idea of who I'm presenting to today, this is helpful for me to know. Okay, I see most of you are using psychotherapy codes on a regular basis. So that's great because that means this should be very relevant to you. Awesome. So crisis coding. What are 90839 and 90840? So CPT code 90839 is billed for the first 60 minutes, but can be used for 30 to 74-minute sessions. CPT code 90840 is an add-on code that's billed for each additional 30 minutes of psychotherapy for crisis. CPT code 99050 is less common because it's not reimbursable by Medicare. So many insurance billers will not cover this code, but it is a code that can be added for crisis therapy outside of business hours. Now, for those of you who are familiar with CPT codes, maybe this doesn't sound like complete nonsense, but for those of you who are less familiar, CPT codes can be kind of a crazy rabbit hole. The thing to understand about crisis coding that is most important is that you can code for the full time that you are handling a crisis. So this is what makes this coding much more relevant in a crisis situation than the codes that you would normally use for a therapy session. And it also makes it much higher yield than the E&M codes that a psychiatrist or a nurse practitioner might generally use for a visit. So crisis codes are standalone codes. They cannot be combined with E&M coding. So if you are using, for example, a 99214, and you would normally do a therapy add-on of like a 90833, in the case of a crisis, you would not use the 99214. You would only use the crisis code. So these psychotherapy for crisis codes can be billed by a variety of different practitioners. Now, if you've done any insurance billing, I'm sure you're aware, different insurance companies will reimburse for these codes differently, and they will reimburse differently depending on your professional degree. So it's not possible for me to easily tell you exactly how much you might be reimbursed as an individual for one of these codes. What I can tell you is that they reimburse higher than standard psychotherapy codes 100% of the time. I can also tell you that they are much more versatile in a crisis situation because you're able to bill for the complete time you're handling the crisis, not only the time that is face-to-face with the patient. So for example, if you have a session with a patient who is in crisis, lets you know that they are not safe, they're contemplating suicide at this time, and you decide in your clinical judgment that it is important for them to be hospitalized, and then you spend the rest of your day calling different hospitals to find a bed for your patient and consulting with the doctors at different emergency rooms to determine that your patient has been safely admitted, the full period of time that you have spent on this crisis can be billed using crisis codes. So that's not only the time during the session, it's also all of the time that you spend calling hospitals, all of the time that you spend consulting with those doctors. If you also had to call family members of that patient and make sure that they were aware of the situation. If you had to call their partner, make sure they were aware of the situation. All of this time is part of the crisis and can be billed using these codes. And you would do the 90839 for the first 60 minutes, and then you would do the add-on code, and you would add that code as many times as necessary to complete the full period of time. So if you are dealing with patients in crisis, this is a way for you to be adequately compensated for that time. This is especially important to keep in mind if, for example, this upended your whole day. Maybe you needed to cancel 4 other sessions because you needed to deal with this crisis. You can be billing for that time. So it's very important if you are dealing with high acuity patients to keep in mind that this is a way that you can be compensated so that it doesn't feel like this overwhelming situation that is just not compensated for. Okay, now documenting.
Michelle, a question came up just from the last slide that I just wanted to define before moving on. Someone mentioned what, if you can go back to the last slide, what's E&M?
Oh, I'm sorry. So E&M coding is evaluation and management. These are codes that are being used by psychiatrists or nurse practitioners that are different than the codes for psychotherapy that are generally being used by LCSWs or PsyDs or PhDs. So if you don't use E&M coding, you don't need to know anything about it. The people who need to use it probably are more aware, but it's a good question. It is sort of a whole different world of coding.
Perfect, thanks. And we've seen a lot of other questions, but we're going to wait till the pause for question times to get into those other ones I see. So keep them coming, everybody. Thank you.
All right, thanks. So documenting a crisis. As you can imagine, insurance companies are not super thrilled to reimburse crisis codes. It's important that those crisis, the crisis that you're documenting be fully documented so that when the insurance company receives this, they are willing to reimburse you for it without putting up a fight. For that to be true, these are the elements that need to be in your documentation. You need a preliminary assessment of risk, mental status, and medical stability. You need the need for further evaluation or referral to other mental health services, if applicable, communication with contacts who may have pertinent information for the assessment, substance use, if applicable, and the outcome of the session. So, as I said at the outset of this, documentation is often a major burden for people in the mental health industry. So this may look like a lot. It may be something that you're like, oh, well, if I have to add all of this documentation, I just don't have the time or energy to do that. I would rather not bill because I'm worried that I'll be audited and I don't know if I can have adequate documentation for this crisis. And this is one way that Spruce is actually enormously useful for mental health care practitioners, because Spruce creates organic documentation by documenting your communication, not only with the patient, but also with all of these outside people like hospitals or family members who you may have communicated with about the crisis. So it gives you a way of documenting without having to do a lot of extra work. So this is an image of a conversation in Spruce. This is a conversation between me and myself. So please pardon my multiple personalities here. My husband and I just got into a fight. I don't think I can do this anymore. It's all overwhelming. I'm thinking about hurting myself. Practitioner says, I'm glad you reached out to me. Are you able to join me for a video call? Yes, that would be helpful. Thank you. We see there's a video call. This is only an 18-second video call because I can't stare at myself for very long without it feeling creepy. But you would assume in an actual crisis that video call would be longer. So this communication is already present in Spruce. And in this case, you can select these messages and copy them and put them into your EHR, put them into your clinical notation that you are submitting for insurance reimbursement. And in this way, this documentation is already organically created for you. So you're not recreating it. You don't have to summarize it. It's also going to show up in a way where you see timestamps. So if, for example, you were on the phone with a hospital for an hour and a half, you would see a phone call to that hospital for an hour and a half, and that could be just noted in your EHR, in your clinical documentation, and the insurance company would see that. They would have that record of like, okay, this is where this amount of time is coming from that they're billing. We have a record of this. So if you were in Spruce, oh yes, we have another poll that's coming out to you now that is about messaging patients. So obviously some practitioners do this a lot. Some people are not doing it as much, and you're going to see, more records of phone calls, but maybe not as much secure messaging or text messaging. So definitely curious if you guys want to answer this poll. All right, so I see there are a lot of you who are using this quite a bit. So for those of you who are sending secure messaging and text messaging frequently to your patients, this is a fantastic form of organic documentation. And for those of you who aren't, if you're making phone calls or video calls through Spruce, you're also seeing the amount of time that those go on. So that can also be useful in this context, even if you're not seeing text messaging or secure messaging like this. So in this case, if I were to go and select these messages and click on copy messages, you can see that there's also a sync to Elation button. Spruce has an integration with Elation, which is one EHR. But I actually often find that copying the messages is the best approach, even if you're using Elation. It just comes out a little bit cleaner. And this is what this looks like. So as you can see, it pastes very cleanly. You can see the timestamps. It is pasting as text. It's not pasting as pictures. So this is going to come through in your clinical documentation in a very clear way, in a very organic way. You can see that those timestamps are blue because they are links back to Spruce. So that obviously would not be relevant to the insurance company. They wouldn't be doing something with those links, but it could be something that you could use to refer back yourself for your own purposes. Okay, let's talk questions about crisis codes.
Okay. All right, so we have the E and M codes. You define that. Someone asked, how are we defining crisis for 90839 and 40?
Right, so crisis is something that, is defined a little bit differently in different insurance contexts. I would say it's very much up to your clinical discretion, whether you're saying that something is a crisis. I think the home runs on this are always a patient who's actively suicidal, a patient who's actively threatening self-harm. I think a crisis might also be a situation in which a patient has suffered a loss and is not functioning well. I think certainly any situation where you feel that a patient needs to be referred to a higher level of care could be viewed as a crisis. It is something that is largely up to clinical discretion. I think that there is probably a gray area there. I would generally say that you need to feel confident that you could fully document it in the way that they're requiring. Otherwise, you're more likely to have the insurance company just say no.
Okay, and feel free to type in follow-up questions. Someone wrote CPT code 96300 or 96301, psychological assessment. Do you know anything about that or anything to add about that code?
Yeah, so if you're doing psychological assessments as part of your visit, those are codes that can be used. Those cannot be used in combination with crisis codes. Crisis codes are standalone codes. The concept of the crisis code is that it contains the idea of there being a lot of complexity and a need for assessment. So you can't add those additional codes to it. It needs to be the only thing that's being submitted.
Okay. Another question that came up. About the code. Well, actually, yeah. So can PhD get reimbursed? So psychologists.
Yes, psychologists can use psychotherapy for crisis codes.
Okay, another good one I like. Can the time my nurse spends with the patient also count towards total crisis time as long as I'm also involved? And this is from a psychiatrist.
Yes. And actually, this is a really good point. I'm glad that this was brought up. If you work in a team where perhaps you have a psychiatrist involved and you also have a therapist involved, maybe there are other staff members like a nurse who are part of this patient's care team. If the psychiatrist has face-to-face time with the patient that day dealing with the crisis, the psychiatrist can bill for the full crisis time, including time spent with other team members, which means that you can be reimbursed at the psychiatrist's rates.
Great. That's really interesting. I didn't know that. Another one kind of similar. Does the patient need to be present for the crisis codes? For example, can this be for telehealth as well?
Yes, this can be done for telehealth at this time. As I'm sure a lot of you are aware, insurance companies are starting to push back on telehealth, and you're seeing different interpretations at this point. So certainly I would review your individual insurance contract to see how they're reimbursing for telehealth and whether they're making any distinctions. But in general, yes, crisis coding for telehealth is acceptable.
Okay. And what about phone calls?
So phone calls are a little trickier because many insurance companies refuse to reimburse for phone calls in general in any way. As part of a crisis, yes, you can include the time that you've spent on the phone as part of the crisis management. I think it would probably be best in terms of being able to properly assess the patient to do a video call as part of your assessment. But I think that you could justify charging crisis codes even if your interaction with the patient was by phone.
Okay. There's a lot of questions, so I'm trying to decide which ones we want to get to first. Someone asked about 99050 and that it wouldn't be accepted by Medicare. Does it also mean that Medicaid probably wouldn't accept it? Do you know?
Yes, I think it's likely Medicaid also would not accept it. Generally, Medicare will pay for more codes than Medicaid will. But again, I think with any specific insurer, whether it's Medicaid or a commercial insurance, you do really need to look at your individual insurance contract, because insurance contracts vary not just by state, but also by individual practitioner.
Okay, then I have a couple questions about some random codes. Do you want me to just see if you know information on those? Or should I skip that question? There's 96127.
Let's skip it for right now, just because the thing with crisis codes is they are standalone codes. So you're not going to be combining them with anything else.
Oh, someone had a question about that. So what about modifiers? So can you do the 95 modifier after these crisis codes for or the telehealth with GTT? You can do that as well?
Yes, you can do the modifier.
Great. All right. Well, we can pause and then you can continue. Then we can go back to the questions at the end. You want to do that? Or I have a few more.
Let's go back to it at the end. Let's talk a little bit about interactive complexity.
Perfect.
So interactive complexity is an add-on code. So as opposed to crisis codes, which, as I said, are standalone codes, they're codes that have to be used on their own. With interactive complexity, this is something that you could be adding to the psychotherapy codes that you're usually using. It does need to be added when there is a psychotherapy code present. So if someone was doing E&M coding, if they were using like a 99214 and they wanted to use interactive complexity, there would have to be a psychotherapy add-on code as well. So you would need like that 90833 in addition. But for those of you who are just using psychotherapy codes in general, this is something that you can add to the psychotherapy codes you're using already. So 90785. These are the times that we might use the interactive complexity code 90785. The need to manage maladaptive communication, caregiver emotions or behaviors that interfere with treatment, mandated reporting of a sentinel event to a third party with initiated discussion of the event or a report with the patient or other visit participants, the use of play equipment, physical devices, interpreters or translators to communicate with a patient who has a language barrier. And at the end here, I've noted again, in terms of E&M coding, if you're using E&M coding, moving to a 99215 is often a higher yield if it can be justified in the given situation. So using interactive complexity may not be for a psychiatrist or a nurse practitioner the best possibility, but it is a very useful code for people who are primarily billing psychotherapy codes. For those of you who work with children, this code is not justified by expected interaction with caregivers, but can be used in more complex interactions. So if you work with children, the expectation is typically that you have some interaction with their caregiver as well. So it's not acceptable to bill interactive complexity every time you meet with a child. However, if you had a situation where, for example, you had divorced parents and one of the parents objected to your care plan and you needed to negotiate between the two parents and try to form, some consensus about what care plan made sense. That kind of situation does fall into an interactive complexity, and that would be a time that you would want to add that code. So this code, depending on the insurance company, depending on your degree and individual insurance contract, may not be a very high yield code. But if it's something that you're dealing with frequently, that small amount of extra income ultimately adds up. So I think it's something that, is worth having in your back pocket and using when it's appropriate, because it does end up increasing your income overall in the long term in a significant way. So this is a nice one to know about and to use when it's appropriate. So documenting interactive complexity with Spruce. This is another situation where Spruce is really helpful in documenting this kind of situation. In this case, I am again having a conversation with myself. And in this case, I am the parent of an adolescent. And I'm letting the therapist know, I want to make sure you talk about this math test. And also, I want you to talk to my son's teacher because I don't think that the teacher understands his learning style, and it might be helpful for you to be in touch with her. Now, if I'm going to be in touch with that teacher on the same day as my session with this adolescent patient, I can add interactive complexity. Interactive complexity can also be added anytime you're sort of adding a third party that is unexpected. So for example, you have an adult patient and they decide that, they want you to meet their partner during your session. This is interactive complexity. This is not a situation where there would be an expectation that you would have a third party as part of that session. This is an add-on. So this also, like, an important distinction to make here is that interactive complexity cannot be billed as part of family therapy or couples therapy, because there is an assumption in those codes that you are dealing with multiple people. Whereas in a situation where it's individual therapy and a third party is being brought in, this is an add-on. It's a difference. So again, this shows how this would paste.
Actually,
So,
Michelle, we've had several questions on how to copy and paste in a little bit more detail. So if you don't mind going back to the previous slide, I can explain kind of how it works. So if you're using Spruce, you can log in on your computer version of Spruce and you can select the patient. So Michelle Brown is the patient. Then you will hover over with your mouse over any of the messages, and a little vertical 3 dots will show up to the right of the message from the patient. And you'll click that and say, select messages. And when you click that, then it will show the screen that you're seeing on your screen right now. And it will have the little check boxes to kind of check whatever messages you want. And you can hit copy messages. And then you will open up your EHR and hit command paste. You can also, if you don't want to hover over, you can also just drag your mouse over the messages, hit control copy, and then paste into your EHR. And as a reminder, that the next slide, you can go to that, is going to reformat this to be date and time stamped. And if your EHR or your source of where you're documenting this allows for hyperlinks, each message will be hyperlinked to bring you back to Spruce. And if there's a voicemail or a video or an image or something, those will be converted to a link so that it will be nicely documented into your EHR. I hope that helps answer the questions. Oh, and one other question someone had, Spruce, does phone calls, text messages through SMS, as well as an app-based. All of this goes into Spruce. So no matter what device or type of communication your patients decide to use, it all goes into Spruce, stored securely, and is able to be copied to any EHR or document in another system. So they don't have to have the Spruce app in order to make it documentable. It could just be a phone call, SMS, etc. So happy to answer additional questions about that. And I see all your questions, and we're going to be getting to those after. Oh, and one other question just came up. The copy paste can only be done on the web version of Spruce. So you do have to do it on the web. You can copy one message at a time by on the mobile, but that wouldn't probably be feasible because your EHR might not be able to be on your mobile either, but feel free to experiment or message into Team Spruce.
thank you.
Yeah.
So interactive complexity, the other one you might have seen on this earlier slide, use of play equipment. If you work with children, and I think especially those of you who have transitioned to doing telehealth with children have probably experimented quite a bit with games that you can play during a telehealth session. Every time you're using some kind of game with your patient during a session, that is interactive complexity. That is consistently interactive complexity. You should always be adding this code. So especially for people who work with children, it's a very helpful one to just be using all the time. For people who work with higher acuity patients, you may have a number of situations that fall into this in different ways. I think one of the more common ones is going to be a situation where the patient is unhappy with your treatment plan in some way, and there's significant conflict around it. This is interactive complexity. You also see here the mandated reporting of a sentinel event to a third party. If you ever have to make a report to authorities of abuse or neglect, that is always interactive complexity. So that's something that you certainly should also be adding. And for example, if you needed to call a state agency to report abuse and you called through Spruce and you were on hold for 45 minutes and you would see on your Spruce interface that call afterwards and the length of that call, and you could copy that into your documentation to note that that was something that you did as well. So just circling back on that. And
I have some questions about interactive complexity. Oh, perfect. There's a lot of questions. This is great stuff. They keep coming. I keep losing them. All right. When you add interactive complexity with a phone call, do you need a modifier for telehealth and modifier 59 happening the same day, is what they said.
So the modifier that you're using should be the modifier you're using for the session. Interactive complexity is an add-on, so it's not being used by itself. It's being used in conjunction with your usual psychotherapy code. So if you're using a code for a 45-minute session and that's a telehealth session and you're using the modifier, you would use the modifier and you would also use the interactive complexity code. But you can't bill for interactive complexity by itself. It is an add-on.
Okay, another follow-up. What if the interactive complexity happens outside of the appointment? Like a patient asking you to call their doctor or therapist. Someone also mentioned, calling homeless shelters, housing, food bank, etc. What do you do there?
Yes, you can add the interactive complexity code to a session that happened the same day. So if you're doing these other case management activities on the same day as a session, then you can add the interactive complexity code to that session. If they're happening on a different day, unfortunately, it cannot be added because it needs to be added to a session.
Okay, great. Yeah, that person followed up with could it be added to the next session? And so it sounds like the answer is no, you need to do it in the same day, unfortunately. Okay. All right, there was, can you use interactive complexity code for EMDR modality?
I'm not absolutely sure whether interactive complexity would be something that would be used with EMDR. I would need to look into it more because I think EMDR generally uses some other codes in addition to regular psychotherapy codes. So I'm not certain what would be the best approach there.
Okay, so you suggest maybe they can look up some resources on EMDR coding and interactive complexity further. So sorry, we don't have the exact answer there. Okay, interactive complexity. Okay, we have another one. Oh, this is similar. So would devices for EMDR, tappers, light bar count for interactive complexity?
Yes, I think if you are using devices, you could choose to bill interactive complexity with a psychotherapy code. I think my question that I'm not certain of the answer of is whether there is a different code that's more specific to EMDR that would ultimately be higher yield. So that would be the question I would encourage you to research.
Someone suggested, I think, a suggestion here. There are no other codes to use with EMDR. So that could be an option, maybe.
Yeah. I mean,
right.
if there isn't a better choice, then yes, you definitely could use interactive complexity with EMDR.
Okay, yeah, someone else said that. If it's EMDR is typically billed with 90834, so it may be able to be added to that. So yeah. Thanks for everybody's suggestions. Can you use interactive complexity during an intake code?
Yes.
There you go. Another question, this may be too specific. So if it is, feel free we can answer later, but interactive complexity, can it be added to 99205 plus 90833 for an intake with a therapeutic component? Quite specific.
Yes. If you're using 90833, then you can use interactive complexity as an add-on. This 90833 is a psychotherapy code. That's the distinction that you would want to, make sure. If you're using an E&M code by itself, then you can't use interactive complexity. But if you do have that 90833, then yes, you can use interactive complexity as well.
Okay. Can EMDR software count as a, in quotes, device?
Yes, I think you could count EMDR software as a device.
And just something to clarify, someone was asking, did you say that play therapy in person should always use the interactive complexity coding?
So the way it's written is the use of play equipment. But I would say play therapy in general, in my experience, uses some form of equipment. So yes, you should always add this interactive complexity code in those cases.
Okay, there's like some specifics about codes, but I think we just want to skip those for now. This was about crisis coding. Do you know if a patient typically incurs a copay or cost sharing with crisis codes? You may not know this, or could depend on the insurance.
Unfortunately, like this is going to depend very specifically on the patient's plan, which I know is frustrating because I do think that there are situations where, you know, a practitioner might hesitate to bill for the full time of a crisis if they're concerned that their patient is then going to have a higher cost on their end. And I'm sorry that I can't give you an exact answer to that because it is so specific to different insurance plans, that it can be very, I can't answer it with any certainty for any one plan.
Yeah, that's always a hard thing to say. Okay, there was one that said, can interactive complexity, can use virtual reality platform at this? I thought that was a fun question because I love the new use of virtual reality. So have you heard about this?
Yes, you can absolutely use an interactive complexity code if you are doing virtual reality as part of your telehealth session.
Awesome. Okay. And if a teen client, 13 and older, and a parent is involved in an unexpected way, could this code be used or is it only for children?
So it could be used. I do want to say in terms of children, to clarify there that with children, with minors, there is an assumption that individual therapy will involve the caregiver to some degree. So it is not appropriate with minors to add interactive complexity just on the basis that the caregiver had some interaction with you. You would need there to have been a more complex interaction, a conflict of some kind, a situation where, you know, perhaps you also had to talk to the teacher or some other additional party. I think, you know, what I see most often in terms of adolescence is that interactive complexity comes into play when there is a problem where the adolescent and the parent have very differing views on a treatment plan. And it becomes a dispute in terms of what, you know, each of them thinks is appropriate. And that becomes interactive complexity. You can think of interactive complexity like if you really look at the words and you think about what that means. Interactive is, you know, you interacting with your client and others. And complexity, meaning your interaction was more complex than would normally be expected in a therapy session. So again, like this can be used for a lot of reasons, whether it was more complex because you used virtual reality, or it was more complex because the adolescent's parent was, you know, screaming at you in your office. These are situations where it's above what you would expect, above what is the standard level of complexity in those interactions.
Okay. And how many slides do you want to get back to the slides and then I can save some of these for the end, or are we, oh, we're good. Okay.
The last slide, give me whatever you have.
Okay, I thought this was an interesting use case. If a client has a regular psychotherapy session earlier in the day, then has a crisis session, can they both be billed on that same day?
Yes. So if they have a crisis later in the day, you would use the crisis codes for the crisis session. And yes, they could both be billed.
Okay. And then All right. Let me go to one of the newer ones. Okay. If there are two people in the room, couple not married, can you do interactive complexity with 90837 or would you use 90847?
So 90847. So if you're doing couples therapy, if you're doing couples therapy, you can't use interactive complexity because the assumption is that you're dealing with the complex interactions of multiple parties. So if you were using 90847 because that is family psychotherapy, you would not be able to use an interactive complexity code. If this was a situation where you were doing individual therapy with one of those people and they decided to bring in their partner for a session, that could count for interactive complexity.
Okay. And feel free, like some of these are very specific. So if you just want to share where they should go for resources as well, may be helpful. I don't mean to do the quiz, the Michelle here. So, we have another poll coming. So this is just for us to get an idea of if you guys are solo practices or if you have multiple clinicians, staff in your practice. So okay, Michelle, the next question I had that was one of the first questions, so I do want to answer it. How often are codes challenged by insurers? And I know it depends on the insurance, but do you have a kind of a general answer for this? Just curious, or just empathy.
I would say codes are not frequently challenged if you are using them appropriately. If you're using them on a level that the insurance is willing to see as expected. So if you start billing for a crisis with one of your patients every single week, the insurance is probably going to say, well, this is ridiculous. We're not paying for a crisis every single week with this patient. That's totally unrealistic. If you are billing for a crisis every day with different patients, but you're probably billing the same insurance fairly frequently, they're probably going to look at that and say, this seems unrealistic. But I will say that the practice that I worked for a number of years did specifically treat very high acuity patients. And we made very liberal use of the interactive complexity code. That was a big one for us. We used it on a lot of sessions. We also used that crisis coding when it was appropriate. And because of our patient population, I would say that it was used reasonably often. And we were not audited by any insurers during the 3 years that I worked there. And these codes were generally reimbursed without too much argument. So I would say if you're using it appropriately, you're not very likely to have a problem. Again, the most important thing is the documentation. So whether you're using Spruce for that kind of organic documentation, or you're using a different service, or you're writing notes in a more traditional way, you want to really check online and see what is required for the documentation for a crisis and make sure that those elements are present in your documentation. And that is by far the best way to ensure that insurance is going to pay out on codes.
Okay. Well, first, Michelle, that was excellent information. And you got a couple non-questions that were just thanking you and just saying how clear you were. But unfortunately, we didn't get to all your questions. They're all so great, but we only had so much time. We already ran over. I didn't realize it was only to the 1:45 hour. So we also wanted to just mention we are doing another webinar next month. Do we have a slide for that? Oh, there we go. So please join us next month, May 16th. This is on the powerful duo to eliminate admin work using Spruce communication system and a virtual assistant. So we'll also include this link in the follow-up email with the slides and the recording. And we encourage you to, use your dependable resources online for your coding. And hopefully maybe we can do another session on this since there's a lot of interest. Thanks again, Michelle. Any other closing remarks?
No, thank you all for listening, and I hope that this was useful. Yeah, I hope many of you are using Spruce, and feel free to reach out on your support threads if you do have any questions about using Spruce for documentation.
Thanks, everyone.